Top Bed Talk.
Great to be here, folks. Hello, my name is Monty Mythen. I was a Professor of Anaesthesia and Critical Care at University College London. I now have an Emeritus position there. I'm the founding director of evidence-based perioperative medicine. Started over 20 years ago when I returned from the United States of America, where I had a position at Duke University Medical Center. I was very interested, along with colleagues in the room, this idea of perioperative medicine. But I must say the spark, even though I think we've done fairly well with progressing perioperative medicine in the UK, came from Ross Kerridge in Australia. An article that he wrote in Anaesthesia News about this idea of the care of patients from the contemplation of surgery through to full recovery. So thank you for that, Ross. As I said, I think we've done pretty well embracing it in the UK. Evidence-based perioperative medicine, I think, was one of the local sparks. Then the Royal College of Anaesthetists embraced the idea of perioperative medicine. It became integrated into our curriculum. More recently, we saw the formation of the Centre for Perioperative Care, or CPOC, which is truly intercollegiate and multidisciplinary. As that journey's progressed, I think us and Australia and New Zealand have very much climbed the ladder together, whether it's educational endeavours or curriculum endeavours or the formation of an international board to try and have a shared curriculum. And as I think we've climbed the ladder, we've kind of reached below and pulled the other team up. So we've been continuously going up the ladder bit by bit. Whereas I think now, quite rightly, Australia and New Zealand's just jumped ahead again because they've recently launched what I think is the first diploma of perioperative medicine, or EBPOM, which we'll hear more about in a moment. I'd like to introduce this year's visiting EBPOM lecturer, Vanessa Beavis, who is an anaesthetist at the Auckland City Hospital and also has an academic position at the local university. She specialises in liver transplant anaesthesia. I believe that's right, Vanessa, is one of your specialist interests. Originally from South Africa, moving to New Zealand, I think, in the 1990s. She's the immediate past president of the Australia-New Zealand College of Anaesthetists and Pain Medicine and the inaugural chair of the Special Interest Group for Perioperative Medicine. So we're going to hear from Vanessa about the progress in perioperative medicine in Australia and New Zealand. Please welcome this year's EBPOM visiting lecturer.
Thank you for that. Kia ora tātou katoa, tēnā koutou, tēnā koutou, tēnā koutou. So greetings to you all. I greet you 3 times from Australia and New Zealand. So thank you very much for inviting me to speak. We've been tackling this for a long time, as you said. And so how it all started was about 20 years ago. I was in the OR down the road at St Elsewhere's and the phone rang and it was, "G'day, this is Professor Michael Cousins, President of ANZCA." And so I'm not going to lie to you, I made some inappropriate response thinking it was one of my mates from theatre next door. So there was this sort of awkward silence. And then it proceeded, and what Professor Cousins was doing, he was doing basically a SWOT analysis of the college at the time, and he set up a whole lot of task force groups. And there were 10 of them all together looking at various aspects of it, and one of them was perioperative medicine. And so that was when we first sort of toe-dipped into perioperative medicine. Ross was on the same task force that I was. And what we had to do was to come up with a definition of perioperative medicine, and we had to decide or determine whether anaesthetists should step out of the OR, where we, of course, absolute superstars, and get into the perioperative space. So after about a year of stuffing around, we came up with a definition. I mean, it's ridiculous now when you think about it, but it took us that long to actually work out that it was from the start of the contemplation of surgery until the patient gets referred back to their primary referrer. And I think the thing about this, though, we've come to realise that it's a pathway. So it's the care pathway from the, go to woe. Whereas perioperative medicine is the science and practice of minimising the risk of perioperative medical complications. And it complements the decision-making that's made by surgical and other teams throughout the patient journey. So the problem that we're talking about is the epidemic of avoidable harm. That sort of turns into the elevator speech about, okay, what is it that we're trying to do? Why are we even bothering with all of this? Now, this is a bit awkward because Dan Sessler is sitting in the audience, but in about 2016, I heard him speak at or deliver the Severinghouse lecture at the American Society meeting. And there he noted that if post-operative mortality was its own special little disease, it would be the 3rd biggest killer after MI and stroke. So it's an enormous problem. And then we finally got the message, I think. It takes a while and doctors like data. So that's the one point. It's a bigger killer. This was noted by Bruce Bickhardt from Cape Town. It's a bigger killer worldwide than HIV, malaria, and TB. If you add all those up together, it's a bigger killer than that worldwide. And just to quote one study, because I have to, read the Reason study, which we were all involved in Australia and New Zealand a couple of years ago. What we did was we took, for a week, all patients over 70, non-cardiac patients, who were expected to stay in hospital for one night or longer. And we just took all covers and looked at the 1-month mortality, 30-day mortality. And what we found was that of those patients, 1 in 5 developed a major complication, and some of them developed more than one complication. 1 in 10 had an unplanned admission to intensive care, and 1 in 20 died. And those numbers, I mean, it's shocking numbers, really. They're absolutely woeful. And it just goes on and on and on. We've had the message repeated multiple times. So I think it's fair to say we do have an epidemic of avoidable harm, and we better get on with it and start fixing it. So why is that? Well, and thank you to Bernard, actually, for coming up with these nice little summary things. So we think it's probably due to inadequate risk assessment in the first place. There's a complete lack of shared decision-making, and it's not just us deciding what we should do with the surgeons or the intensivists, whatever. There's no patient involvement in this either. Failure to rescue and post-operative care. So I'm going to touch on each of these 4 issues generally, just at a high level, in the context of where we are in Australia and New Zealand at the minute. I'm going to talk about risk stratification, and we've heard a lot about risk and optimization in the past 2 days, and then talk about our diploma, which we think is going to help with the fragmented care, shared decision-making side of things. And then I just want to touch finally on a paper that's just been published last month in JAMA by Professor Ludbrook and his group from Adelaide. So the mugshot you see here is my office mate, and that's Dr. Doug Campbell, and he has developed a risk calculator for New Zealand patients. So obviously, I mean, prior to surgery, patients and clinicians decide whether to proceed with the surgery based on their risk, the risk-benefit. I mean, that's what it's all about. And as you know, older patients with underlying diseases, and the risk of dying, not to mention the morbidity, is quite significant. So if you can't give patients proper information, then and certainly your colleagues, how are you going to advise them? So what we have is NZ risk. It's specific for New Zealand conditions. It's a really, really simple calculator. And this, and here I need to say thank you very much to the usual suspects, because it's based on the SORT tool, which is used here in the UK, and as I say, developed by the usual suspects. So that's Professor Ramani Munasinghe, Mike Grocott, and Monty Mythen. So we use the same limited preoperative covariates, which is age, ASA, presence and absence of cancer, the specialty, severity and acuity of the problem. In New Zealand, we've also added gender and ethnicity, because both of those things are very, very important. We're very fortunate that we've got a massive data set. We've got data in New Zealand coming out the wazoo. And this particular thing is very useful, 30-day, 1-year and 2-year mortality. This has been around now for about 10 years, and we're going to advance it as well. And the same data set or way of doing things is being developed in Australia by Dr. Jennifer Riley. Now, if you look at these calibration curves, if you look at observed versus predicted, and if you put the UK data in, it's really very, very good. The area under the receiver operating curve for this one is around about 0.91 or something. It's really good. If you look at SORT New Zealand, we tried it, first of all, just putting in our data into the UK model, and it was really good as well, but it wasn't quite so good once the predicted risk started to go up. So there was a little bit of divergence there. So when we did NZ risk and added in our additional 2 covariates, so gender and ethnicity, it suddenly was absolutely spot on, and you can see it's a pretty good calibration curves. We've got a lot of data in there. We have every patient over 18 that's been submitted to this. Public patients, private patients, gender, ethnicity, all of the rest of it is captured by a national minimum data set, and so we've used that. You can see in all of them, though, that the curve goes pretty much through 0, so that there's very limited bias in any of them. Now, you may wonder why we spent all this time and money developing our own thing. I don't know if you've heard of the Gompertz-Makeham law, but what that means is that this is kind of death rates, just in the general population as you go. And it's a sum of an age-dependent function. So you can see in the beginning, there's a tiny bit of infant mortality, and then the rate drops way down, and then it rises again once young males get drunk and go out and do stupid things, and they kind of crash, and so the death rate goes up, and then you start running into the obstetric problem. But the inflection point is at about age 30, and then after that, it's very predictive as the death rate starts going up steeply from then. The thing about this is there's an independent factor as well, and so in a protected environment where you're not having a war every 5 minutes or some ghastly thing, the mortality follows that way. So I just wanted to give you an example of how to use Doug's NZ risk. So I took a standard patient, which will just be the usual thing, sort of 72-year-old man, a European, or Pākehā as we'd call it in New Zealand, ASA3, so the standard hypertensive, diabetic, sort of fat person, having a Hartmann's procedure for cancer. Specialties, general surgery, subspecialties, colon, and colectomy was the procedure. And then, yes, I wasn't a robot, so I was able to calculate it. And it's got a helpful thing on the side, what they mean by cancer. And so the graphs that come up, what it shows you over here, it's a very easy way of explaining to a patient where their risk of dying is at 30 days, 1 year, and 2 years. The scary thing for me here is if you look at the mortality for a Maori patient, it's almost double for the exact same patient. So this is why ethnicity is so hugely important for us when we do our calculators. The effect of gender wasn't quite so marked, but it was still marked. Females actually do better than males in both Pākehā and Maori populations. I think you'll probably find that this is the same in every single country where there's been colonisation. Certainly the Canadian numbers are similar, and it's the same in Australia. So that's why we absolutely 100% have to have ethnicity there, and it's a big problem for us. If you look at the centiles, if you divide that 30-day mortality using Doug's calculator into centiles, and you look at all the numbers, and we're talking 30-day mortality, if the predicted mortality is less than 0.5%, then, and there's a huge whack of patients there, it's 11% of the deaths. The next group, which sort of form the intermediate group, which is 0.5 to 1.5, is the next 12% of deaths. But if you're talking the 30-day predicted mortality of 1.5%, which doesn't sound like much, you've got 78% of the deaths in that group. So it's a way of being able to risk stratify and to triage where you should put your effort, and also where you could argue that really, why are we bothering seeing all these patients in the clinic, the low-risk ones, when actually we should be spending our time concentrating on the other ones. And all it requires is quite a simple calculator, which has been well validated, so we're confident with it. Now, of course, it's not just mortality that's important to people. Obviously, morbidity is hugely important. And so, as Paul Miles has told us, days alive out of hospital is a very useful indicator of in-hospital quality of care. So the next version of NZ Risk is going to have days alive out of hospital at 90 days and hospitalisation during that time as non-fatal outcomes. We're going to look at the baseline and additive risk, and that means we're going to be able to use that Gompertz Maycomb law because it's been validated that follows NZ Risk fits in with that and is aligned with it. And then we'll be able to embed it and do all sorts of amazing things with IT and have a better website so that everyone can get some more information, etc. So it's very important because at the moment what we're doing is we're using a combo of NZ Risk, which is mortality, and some other morbidity thing like NESQIP, for example. The problem with NESQIP for us is that it doesn't really apply to the New Zealand population that well. There's a lot of missing data and stuff, and so it's good because it's a massive website, but at the same time it's not quite right. And the other thing it doesn't do is it doesn't tell you about the impact, it just tells you what the complication is. So, it describes the same sort of value or lack of value, if you like, to a stroke versus an MI. And I think most patients would possibly rather have an MI than a stroke, given the consequences on their day-to-day life. So I really hate it when the evidence doesn't support my opinion. I can't stand that, and it happens often, I'm afraid. So we really do need large trials to kind of help us out here. And pragmatic trials that sort of influence clinical practice are really, really important to do. What we need to do is replace opinion-based medicine with data. So one of the things we're very proud of at ANZCA is our clinical trials network. And so have you ever wondered whether you are actually doing the right thing for your patient? And And so I think the Clinical Trials Network helps us there. We established it about 20 years ago. It was established by ANZCA Council, and it's been supported by both college and peer-reviewed grants ever since. So a portion of our subscriptions every year go towards the Research Foundation. The Research Foundation distributes funds, which it's a competitive process where people can apply for it. And there's a small amount, about 15%, that is available to people who need to do something in a global development sense. Because for those kind of projects, a little bit of money really does go a very, very long way, particularly in terms of training and education of the local healthcare providers. So it's ensured engagement by ANZCA fellows right across the board with everything that happens, and completing trials, and the trainees are able to contribute as well as implementing findings. So we've recruited more than 55,000 patients via this ANZCA clinical trials to date. You'll be familiar with some of those names: Poise and Masterstroke and Balance, all of those, which are well known to you. At the moment, we are looking at lidocaine or lignocaine. I still can't get to call it lidocaine, to prevent chronic pain and cancer recurrence, and ketamine looking to prevent chronic pain, and TXA to prevent surgical site infection. And the thing is, you need large trials because of equipoise, and in the research space, you get a bunch of experts in a room and they can't agree on whether a particular treatment is good or bad, or whether a particular drug is good or bad. And so that's why you need large trials. And these trials are usually controversial. They often don't give you the answer you were expecting, or they don't give you an answer. You still need to do a few more. But they are reproducible, applicable to everyday practice, and very hard to ignore. So crack on, everybody. Keep going with the big trials. So moving on from research, which I think we need to be research-driven and evidence-based, EBPOM, to our diploma. We realised very early on, even though it was 20 years ago while we were trying to put it all together, that the perioperative space is not owned by one single discipline. It's not owned by the surgeons, nor the anaesthetists, nor geriatricians, intensivists, etc. No single craft group has got the full skill set to, in fact, look after a patient from the moment of contemplation of surgery until they're referred back to their primary referrer. So as a consequence of that, we decided we really do need to get everybody into the room, and we need to make it better for patients. And so that then resulted in a major collaboration of associated colleges and societies. And the colleges that you see up there are the binational colleges, or in the case of GPs, just New Zealand ones, and the Australian ones, because we think that they are the ones, their fellows are the ones that touch the patient along the whole journey. We've been very fortunate to have been assisted and collaborate, and we are blown away by the generosity, in fact, of CPOC and the Royal College, who have been amazing in terms of their support. And we've just signed an MOU with CPOC to advance world domination of perioperative medicine. So I think it's a great thing. The amount to actually get specialists of different groups in the same room together, actively cooperating and collaborating, is pretty good. I must say, what we're trying to do with this diploma is to get the same shared mental model between all the medical disciplines. If you think about it, if we're talking about fish and we agree that we like fish, I'm most probably thinking about grilled salmon for dinner, but you most probably would be thinking perhaps about tropical fish, beautiful tropical fish floating around a coral reef or something. So yes, we all like fish, but the outcomes are quite different. We have a different mental model, so that's what we are trying to do. So, no talk on perioperative medicine would be complete without the pathway that we use. There are many, many of these pathways, and we fondly call it the nephron. I used to call it the snakes and ladders thing, because there's 2 points where you can actually exit the pathway and not go forward for surgery. And the point of showing you this is 2 things. First of all, the whole thing is underpinned by shared decision-making. I think everyone would agree that the person who owns the problem, that is the patient, needs to be involved in all of this. And we can't just keep doing things to people. They need to be with us, nothing about me without me kind of thing. So the second point of putting this up is that all the learning outcomes are related to the 6 stages that are shown there. So everything is driven by the perioperative care framework. It's not just some random thing sitting around the table working out how to do it. Again, you will have seen a similar slide yesterday. Basically what it is, it's possible to do this diploma over a whole year, 3 10-week trimesters with 2 units of study done per trimester. There are 5 important areas within each module, and all of those have got about 20 different topics that have to be looked at. There are 3 things that cross through all of these modules, okay? And one of them is patient care and practitioner well-being. Well-being is very important for everybody, not just the patient, obviously. Communication, again, is a key thing that is a thread right through. And then cultural competency or safety, which is probably a better word now, diversity and inclusion. So those three things are fundamentals that go right through. The diploma also is based on or aligns nicely with the CAN-MEDS principles, which our training scheme is modelled on as well. So this fits, all the learning outcomes fit in with that also. A very critical part of the diploma is that we reckon it will take possibly about 8 hours a week per unit. 4 hours of that is clinical immersion time. So there's no other diploma that requires actual time in the clinical environment for this. And then the rest of it is, the other 4 hours is made up with some online learning, which will be case-based discussions and interaction with other participants and that kind of thing. There's going to be an assessment, obviously. To the dismay of many, it's not going to be a final exit exam. Apparently that doesn't fit with modern education now. You've got to do it as you go along. It's sort of assessment by a million cuts, if you like. So there's online tasks, there's WBAs, short answer questions, workplace-based assessment, and simulation where necessary. So the communication stuff we will outsource to a company that will do it, and using actors and that kind of thing. So it's a very broad assessment. It's able to be undertaken by any of those craft groups that I mentioned earlier. Now, to do this, you need to you can't start a diploma without having a faculty of people who can do this. So we need to have some way of getting people into it. So we've got a grandparenting process as well, or recognition pathway. To get recognised as a diplomate of this in the grandparenting thing, which is a very short window, so that stops in December, you need to achieve 1,000 points altogether in those 4 sections. You have to do, the only mandatory one is clinical practice, so you can't have someone who is very important sitting in an office as a diplomat of this. They have to do some practical clinical stuff as well. That section D, we allowed each of the participating colleges to set the requirements for what they thought would meet the definition of a complex perioperative medicine type of situation, remembering the care framework, for their particular area, 800. And then you need to get some other points. So a Master's of Perioperative Medicine, for example, will give you some points, teaching, development of clinical guidelines, that sort of thing. So 1,000 is what you need. And we are doing very well with that. We've got about 200 people who have submitted applications to be grandparented. So in summary then, the diploma is a 1-year, 3-trimester clinical diploma. It's not just a whole series of, do it online kind of thing. Open to anaesthetists, surgeons, physicians, intensivists, and general practitioners. The GPs at the moment are working out their clinical criteria for their clinical practice, section D thing. And it's going to be online, face-to-face workshops. Each module will have a full day get-together face-to-face, as well as some clinical immersion. Programmatic assessment, not just the whiz-bang exam. We've got grandparented people, and we're starting with our pilot sites. September this year, there'll be 10 pilot sites across Australia and New Zealand. So more or less, bigger states in Australia will have 2 sites, and there's one in the North Island, one in the South Island of New Zealand. Moving on now to the post-ops section, which I just wanted to touch on as well. This paper was published in JAMA in May, just recently in May, and again, the usual suspect, Mike Grocott, was involved in this, but Guy Ludbrook ran it out of the Royal Adelaide Hospital, fondly known as the RA, in South Australia. And what they did, the question that they were trying to answer was reduction in complications and healthcare utilisation when you divided patients into 2 groups, the usual care, which means you go to the ward, and the advanced recovery room care. So what they did was they took patients, they propensity matched them, and they had about 400 and something in each group. Non-cardiac surgery, patients who were expected to stay in hospital 2 nights or more. And they put them through the NESQIP calculator, and they picked patients that were medium risk. So low risk, of course, are expected to do well anyway, and high risk are obviously going to go to intensive care, you hope, if there's a bed. But the medium risk ones are the ones that are often they're okay, of course, because we're watching them closely during surgery, and then they kind of flounder afterwards. So that medium risk group, 400 in each group, usual care versus advanced recovery room care. Now, what's the difference between that? Well, usual care, go to the ward, and basically you're on your own. The nursing ratio is 1 to 10. And so that's, you have to be pretty good to survive in the ward. Advanced care, it's a much better nursing ratio. 1 to 2 is a nursing ratio. We're able to do invasive monitoring. were able to run inotropes, and the only thing they didn't do is, other than using CPAP for somebody's OSA, they did no ventilation at all. It highly protocolized with tight interventions as needed and run by a specialist anaesthetist. And at the end of the 24 hours, the patients either went to the ward or they went to intensive care, depending on how they were going. So the results: there was no change in the mortality, the length of stay, readmission, or the number of ED visits for those patients. There was a difference, though, in days alive out of hospital at 30 days and the number of medical emergency reviews. So just to touch on the medical emergency reviews, what it showed in the first 24 hours, there were 4 times the amount of medical MERS interventions in the ARC group, in the advanced recovery. That's not really surprising, is it? Because if you're watching for problems, you will find them. So 4 times the amount compared with usual care. But then you go to the ward, days 2 to 9, and suddenly the usual care people have got 3 times the number of interventions that are required when somebody notices that you need help. And that translated then into days alive out of hospital of 17 days for the advanced recovery room group versus 15 days for the usual care group, which is actually quite a big difference. 2 days at home. It's good. So it's really promising data, and I think what it illustrates in a way, following on from previous talks, is that it's very difficult to get a positive outcome from a single intervention. So I was thinking of balance when I was thinking about this. It's hard if you're just doing one thing, but a whole package of care, you're much more likely to be able to demonstrate a difference. The problem is, of course, you get compliance problems when there's a package of care. But anyway, I guess the answer is we need more studies. So in conclusion then, when you risk assess a patient, you need to have a tool that's related to your own population. Others are good, but your own population is by far and away the most accurate thing. We think that the diploma is going to be a key enabler for dealing with the fragmented post-operative care and the failure to rescue. It's going to give everybody the same mental model, and we're starting there with the medical professionals because you might think that they all know it all and they just need a little bit of tweaking, but they don't. The post-operative care, I think, is where we can get the biggest benefits in terms of patient outcomes in the long term. Pre-op optimization, of course, is very important. But given that a large percentage of our patients are acute patients or present acutely, there's not much we can do in that time. I suppose you could stop smoking for 2 hours, but that probably won't do much good. And then, of course, research should determine the direction. Thank you very much.
Thanks for downloading TopMed Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMed Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.